Hey y'all, happy Baby Friday. Hope everybody's having a good day. We have a whole nice little group for us here at the beginning today. So I am pleased today to be joined by a lady who's going to be my main guest. So hey lady, thank you for coming
Hey,
on.
thank you for inviting me. I'm so excited to be here.
Of course. And then I have also on the line with us Kimberly Jolivet Williams. And of course, y'all all know my good friend Sonal Patel too.
Hi.
So before we get started on our discussion today, which is going to be on all things GI, so we're going to have our tummy talk. I thought I was very clever with that, by the way, y'all.
I love.
I love it. I love it.
I wanted to take a few minutes to talk about an upcoming event where all of us will be on. So I thought we'd take a few minutes to kind of go through that today. And it is the lovely Miss Kimberly Jolivet Williams Virtual Business of Healthcare Colloquium. That's a mouthful, Kimberly.
I know. I know. I love the term. I didn't realize how much of a mouthful it would be with the name of my business, right? But when I was an adjunct instructor years ago for Dallas College, they had an event and they called it that. And I said, if I ever have to have events, they're going to be called colloquiums. I love that term. It stuck with me.
Well, nothing wrong with that. But we are all going to be guesting with Kimberly for the weekend, different ones of us on different days. So interestingly, and I think it's a fabulous idea, Lady is going to be having her presentation also in Spanish available, right, Lady?
That is true. Like where I'm gonna translate it in Spanish, like the understanding of screening colonoscopies for Medicare patients. So yeah, it's completely full in Spanish. That's my first language. So I'm very excited to able to present it to, in my language. So very excited
Wonderful.
for that. Yep.
Yes.
And Kimberly was nice enough for our listeners to give us a promo code to get $10 off the colloquium price. So if you use the promo code CHCS10, then you'll get an additional $10 off the registration. And Kimberly has nicely extended that through tomorrow. So y'all can go ahead and get in and still do the savings before the colloquium starts on Saturday. So it's this Saturday and this Sunday. Now, Sonal, what are you going to be speaking on at the colloquium?
Yeah, I'm so excited. I love this annual fall event. It's one of my favorite sessions.
Oh, thank you
And
so much.
yeah, no, it's honestly incredible because you always come up with a lineup of, home run speakers. So it's just fantastic, fantastic. So anyway, I will be present throughout the weekend, but I'm talking on Sunday at 12:30 Central Standard Time on what I've been talking about this past year on the E&M audit standards for 2023 and beyond. I think it's a pretty critical hot topic still because as we know, there's a lot of post-payment audits that are rolling out for those E&M services in 2021 when those guidelines came out. So I think this topic is still in the news. It's still hot. We need to do a lot more to get compliant. So I'm excited for Sunday.
Yes.
Thank you so
Yes.
much. I'm excited too.
Yeah,
What are
me
you
too.
going to be speaking on, Kimberly?
So I actually decided to do the potpourri of social determinants of health. And I love using that potpourri term, right? Because to me, it's just a little sprinkle of everything, which when we think of the big scope, especially with social determinants of health, it's the revenue, it's the medical documentation, it's catering to the patient. And then, like we talked about recently this week, how do we handle that, right? What are the risks? What are the limitations and the liabilities? What do we need to do to make sure we can alleviate or try to facilitate alleviating some of that? So I'm excited about that. This is my first go at it. So hopefully everybody will give me a little grace and a little feedback. But yeah, I just
Cool.
got to do social determinants of health.
Cool. So you're going to have the two big things, the potpourri at the colloquium. So
Yes.
Right?
Leave it to me, right? And Jolivet Medicoding, right?
Now, mine is going to be shorter, OIG. So I'm doing OIG updates.
So relevant, though. So relevant. I can't wait to hear that.
Yeah, I can't wait to hear that one.
Great.
Oh,
That'd be great.
good. Thanks. Yeah, it's you know, I was trying to think of things like the one I just did for the Society for Healthcare Business Consultants on the racks. Things that are out there that we like hear about and know about, but those that aren't like heavier on the consulting side of it know what they are, but maybe don't know how to use it or what things you can find out about them. So I went through on the OIG site and show you all the different stuff that's available up there and where to go and find everything. So hopefully, you know, it'll be real helpful for people. So I like that.
That's going to be phenomenal. If it's anything near what you did for them on the rack, oh my goodness, it's just going to be phenomenal. I have shared with you how much your rack presentation helped me in my current situation right now. So I just can't wait. I know it's going to be so informative and exciting. And I love the resources because of you, I knew where to go, right? What website to go to, where to look. I love that. I love that.
I second that, and I was gonna say, like, because of 3 of you guys, I was able to pass my CPMA.
Fantastic.
Yeah, and then and I'm just gonna say too, a shout out to Natasha too, because she helped me with
Yes, I love
oncology.
Natasha.
Yeah,
Natasha Timberlake, she is amazing. Yes.
yeah.
She is, and she
Yes.
put up
Oh,
a
she's there. Hi.
she's here. So hey, Natasha.
Yes.
Great.
And also I see Catherine Rose made a comment in there about your bilingual presentations. That
Yes,
so
and there's a couple more
looking.
also. Yes, to
Yeah.
share. Gabriel Aponte Moberg, he's speaking on risk adjustment, CDI opportunities in new V28 risk adjustment. He's doing that both in English and Spanish as well. And so is Kim Montenegro. She is speaking on from CPC to CRC, what I wish I would have known. And she was kind enough. She did hers in both English and Spanish as well. So I have at least 3 that are in both translations. And I am so appreciative to them for doing that because that's like double the work, right? But I know the Spanish community will appreciate it as well. So yes, if you're interested, come in and you can earn your CEUs and you can learn them in English and Spanish.
There you
go. Nice. Good. Well, alrighty. Well, thanks, Kim, for giving us some of your time today. Like I said, I know you're real busy and involved, so I'll let you get back to you know what you're doing for your physicians over there.
Absolutely.
But we'll see you Saturday.
Yes, it was my honor to serve all of you. Make sure you have a thriving Thursday.
Thanks, hon.
Bye, Kimberly.
Bye, Kim.
And then Sonal will be coming back on at the end of our hour today because she and I have something we were working on together and we want to kind of tell everybody about it. So y'all on our thing today on the healthcare happenings are going to be like the first ones to hear about it. So she'll be back in a little bit. So thanks, Sonal.
Okay. I'll see you guys soon.
All right. So that leaves you and I, lady.
Yes.
So good. So just for people that are listening in here that might not, you know, be knowledgeable about yourself yet, although I'm sure you and looking in how you do your posts all the time and put your motivational stuff out there, many people know who you are. But just to get a little more background information from you, you've been in the healthcare field now for how long?
I've been in the healthcare for like about 14 years already. Like I started back in 2008 when I make a decision. I used to be a delivery driver for Express Mail, and I used to carry a lot of boxes, and it was bad. So I was pregnant in 2007, and then my partner told me that, you know what, you need to do something different. This is not good for you. You're so smart. Just try to do it. And he called me smart, so that was a good thing, right? So so then I was like, I'm looking around to see what could it be good for me, and then I came up with medical billing and coding office management. It was just a course, a diploma. So I went to a trade school and I did it for 6 months and 2 months of externship. So that was total 8 months. And I was able to be working at a chiropractor office. They hired me right on the spot. They really liked that that I was very knowledgeable. I was very like into it. So everything started back in 2008. Like a year later after I graduated, I applied for a primary care office for a PCP. And then, so I worked there for like about 10 years.
Oh, good.
Yeah. So that's where I learned everything that I know, pretty much everything, like the majority of it.
So what was it about healthcare, the field that kind of, interested you, that pulled you into it?
I think it's this field. What I like about it is that give me the opportunity to make a difference, to make a positive impact in others. Not just like when I was in the primary care, I really like because it was in a community that it was just Hispanic. So it was more like a geriatric. So I was able to help the people that they were like at the elder people, seniors. And then especially for Medicare, some of our community, my Latino community, they don't understand a lot of the nuances about Medicare and what they Medicare, like the benefits. So I was very fortunate that I was able to help a lot of patients. And then I think that was kind of got me into, like, it was very rewarding that they were coming in and said, thank you for taking the time to do this. And then that's one thing I learned, like, when and goes to people that works in primary care, or anything in general, you kind of have to have a compassion heart when you're treating patients. You already, like, they already come in with the problem, so you don't want to be another problem to them, right? Treat them with respect, treat them with compassion, and then put yourself in your shoes. That could be a member of your family. You want to treat him like you want to make, like I said it a few months ago, you want to treat them even better than your own family sometimes, right?
I was going to say, yeah, there's some people that maybe I wouldn't want to do that to. Yeah.
That's true.
But yeah, and I remember working in the offices when I was in the clinics all the time, and it was when you would help patients and do things with patients and for them. There were just certain practices that I worked with, like Christmas time, a month's worth of food, was coming in from the patients. Those were
Yes.
always the offices that you could tell which ones were like helpful for their patients, because they show their gratitude in those kind of ways where they were always bringing that stuff in, and we would have chocolates in the freezer for like the next 2 months because there was just too much to eat, and cookies and everything else. So it's very nice to be able to help people like that.
It is. To me, it was rewarding, and then I think that kind of helped me out to where I am now, and like how do I conduct myself, because then I always think about what impact that I'm giving to the patients, especially if you kind of like have more contact with patients face to face. You always want to make sure that you treat them with respect, and you treat them with you be more like compassionate to them. Like sometimes they already having with the problem, and it's not that some of them, they might be saying, you might be thinking, oh, they're mean or they don't have, but you also, it's not about them, it's about you and how you treat them, and it has to start with you. That's how I see it.
Well, yeah, and they're sick, they're not feeling good. Yeah, they might be cranky, but that's why you have to, treat them in that manner so that they understand. And it's not, even when I'm talking with coders and about ones that kind of get hesitant about talking with the physicians, because they're like, well, I said, you have to understand, they're not upset with you, they're upset with the situation that's happening because of what's going on in the industry, blah blah blah. So it's the same thing with the patients. Exactly. They're not upset at you, they don't feel good, they're frustrated because they don't know what to do, and that's why they're coming to you. So when patients are like that, that's what I always used to think about, is this, like, I know they're really not feeling well, so you just help them, and by the end of the conversation, then their attitude gets much different, because they got what they needed, they feel more they feel better about the situation, they're not as anxious. Exactly. And they're like, okay, and then everything is good. So
you have to make the difference. Yeah.
Yes. Kimberly put one of her Kimberlyisms in here for us.
We have to give a little grace.
Yeah. So we have to give a little grace. So yes, definitely, Kimberly. So in all that primary care time, then, like kind of what sparked you into GI then?
So I was in a primary care, like I said, like that. I lasted between 8 to 8. I think it was like about 9 to 10 years. So then I
Mhm.
said, okay. So I started like, okay, I need to challenge myself, right? So I was like, I was feeling already on a comfort zone, and I was like, no, I really need to. I need something else. And something was like telling me, like, so at that time, I was already studying for my CPC. That was in 2017. And I didn't want to leave the company, the primary care, because I wanted to make sure that I will get enough credit for my, to remove my A, because I knew there was the
Mhm.
A. So, but I was like, oh my God, if I leave, then I'm going to lose all those years. They're all going to go away, right? And I said, no, I cannot just think like that. I had to think. And then there was an opportunity. And it was funny because the opportunity was just across the street from where I was working. So that day I sent my resume, and then it was funny because I sent my resume. The doctor was looking for a biller because he needed to transition. He was outsourcing it, and you never see it that you outsource and you bring it back to in house. But he wanted
Mhm.
it to do it in house. So I told him, hey, I have all these years of experience. I'm starting to become a coder too, and then so you will have all that. And then I didn't know anything about GI, but then when I interviewed him, I say, you know what? If you make the decision to hire me, by the time that I get hired, I am going to know everything that I need to know about GI, because I feel like I'm a very research, and I like to keep researching, and then I like to be equipped for what I'm going to be doing. So he hired me. He's like, you know what? I don't know how you're gonna do it, because he knew the doctor, my the primary care doctor, and he's like, I don't know how you're gonna do it with that, because I don't want to get a conflict. We used to refer patients to him, but I left, and it was an opportunity. A year later, I became a billing manager for the company. I took over everything. I feel like that was a very like a game changer for me, because I learned so many different things, aspects on the revenue cycle, not only on the billing, but also navigate to other areas such as contracting, credentialing. I was able to pass or get the surveys for the JCO, for the facility. For we had an ambulatory surgery center that we built from scratch, and then we passed all the credentials, Medicare, Medicaid. We were able to get all the contracts with all the major and companies. And I would tell you, I was very proud of that, because I didn't know anything about contracting, and I handled it. And I didn't know how I did it, but I did it. And then I secured very good contracts for the hospital, for that. I mean, not for the
Good.
hospital, for the ambulatory surgery center.
Yeah, and Jayco's tough. They're
JCO is
tough
off.
to when you're getting them to come on site and they're looking under every,
Hmm.
surgical tray and everything that you're doing and every pos. So yeah, Jayco, when they come on site to kind of look you over,
The
those
surveyors.
are pretty intense. Yeah.
Yeah,
So
they
that,
are, and it was hard, but I feel very proud that I was able to get that
yeah,
knowledge, and I have it on my background. Even contracting or credentialing,
yeah.
it is, especially in California, to get Medicaid, like Medi-Cal in California, it is a very hard. The application process is very difficult, so you kind of have to do it from like the right from the, because then it will goes back and forth. So I with that, I think I'm very detail oriented. That's one of the things that I have. And then I like to do things. I don't like to submit anything if I wasn't sure. So, and then I think I got a compliment from someone in the Medicaid. It's like, you know what, this is the first time I get everything, all the documents, everything. I was like, I wanted to get it sure on the first try.
Mm, yes, being detailed oriented is definitely a plus in what we do. When we get
Mhm.
into something, we got to make sure you get requests for additional documentation, those ADRs. Got to make sure that everything you send them is what they're asking for, and that you're not missing things, because it could have a bad outcome if you miss something that you should have had in
Yeah.
there. So all of those little kind of things, I think those kind of personality traits are very needed, for
Yes.
people that are in our positions in the healthcare side. But I know, that you now have a new position too, though, right?
I do. And yes, I do. I currently serve as a coding supervisor for Whole Health System. It's a hospital in Newport Beach, California. They're expanding. We are growing. And then I got this opportunity, and then so it expands my responsibilities now. I'm not doing a lot of coding like I used to, But I'm happy to be on this organization because it has great leaders, and then and I'm able to help other coders and guide them, and walking through or giving any guidance to my colleagues. So I'm very super excited to be part of this new hospital.
That's good. So out of all the stuff you've done and what you're doing now, what do you love most about what you're doing in the healthcare field?
I think well, right now, okay, when it comes to coding, I think now I'm enjoying more being an auditor. Like that's what the reason why I got my CPMA, and I think that's where my direction is going to, like becoming better in auditing and making sure that when you auditing, you're giving a good feedback, right? Because that's the purpose of the whole audit, and that is what it is. And if I'm going to be auditing, like let's say percent my colleagues or my the staff, then I can give her a good feedback. Why could it change, or giving my recommendations without judging the coder or what they're coding. It's basically, I'm not judging the coder, I'm just reviewing it, and that's it. And I'm giving a recommendation, nothing else than that. So people have to be like not taking it personal. I was at it before when I used to work in my previous company. It wasn't what I expected, but then I took it. I'll say, okay, you know what? This is a good opportunity for me to learn. Take it from there and then improve yourself. That's all what it is. It's nothing personal. So they shouldn't be no hurt feelings. I know we all we don't like to be kind of like judged in what we do, but sometimes it's needed.
Yeah, yeah, and I think that that's a good thing that you said. It's attitude on both sides, the auditor and the person being audited, whether that be a physician, an APP, another coder. You have to take it as it's meant. It's not meant that you're coming after somebody and trying to get them, or you're looking to help improve them and help improve the organization and to protect everybody. So,
Exactly.
in the way that, the auditor approaches the person that was audited, kind of sets that tone. And then the way
Mhm.
the person that's being audited accepts it. So I always try when I audit, when we're giving results, that we always start out with, overall, y'all did really great. I don't always
Mhm.
start with, oh man, you did so much wrong, or, oh, this is really scary. There's no point to that. Then everybody's already tense and nervous and on the defense.
Yeah.
So I always like to start out with the positives and kind of pepper in where we need improvement. And I always like to tell them, we just have to tweak a little bit. We just tweak things. It's not like everything was wrong. And,
Yes.
you want to make sure that it's comfortable for everybody, because it's not comfortable for me as an auditor either. To the idea of sitting there like hammering on somebody,
Mhm.
I don't, I wouldn't enjoy that.
Yeah.
So yeah, but auditing is definitely very interesting, and I like it too, because you get the variety also. One day I'm looking at E&M, another day I'm looking at surgery, one day it's
Yes.
for orthopedics, another day it's for dermatology, and all that kind of, so you can get more of that expansion of what you're looking at. So it keeps things interesting to where you're just not
It does.
looking at the same thing day after day after day. Because for me, and I know for some people, they're like, that's how I like it. And that's great if you do. But for me, I couldn't, I had
I'm
to
the
be doing
same way.
something different. Yeah.
I'm totally the same way. I like to have different options. I don't like, because I feel like, oh my God, without this role, I really like it because then I can able to touch different areas. And there are areas that I'm barely starting to understanding, like OBGYN. I was never into that specialty. So now I had to kind of learn it, because I don't code it, but I want to make sure that the people that works for, that I guide them, I can able to give them the good resources and the good feedback or whenever it's needed. So I need to, there's a lot of things that I had never touched before, and then now I'm finding myself doing it. So I was like, okay, it's time to kind of get the knowledge on that area. So yeah, I love it that I'm able to do different things.
Yeah, and that's one of the things when we say in our field also too, we never stop learning. So,
Never.
if you're shifting over into places or pulling in some new stuff, there's always something new to learn, and there's always changes every year anyway with everything. So, we have to have that attitude of being a constant learner and
Yep.
actually enjoying it.
Yes.
Otherwise you're going to be pretty unhappy. I would say.
You always had to, you always, like I tell my kids, you always have to have room for improvement. I mean, like I have a soccer player that he thinks he has such talent, right? He does, but I say, hey, don't think too much of you. Like you have to continue doing it over and over and over. And then, that's just the way it is and everything in general.
Yep. Oh yeah. And Kimberly, she's like lifetime learners indeed. Yep. And just before we move on to our things too, like Jill and Catherine both, or giving you congratulations on your new position. So I just wanted to kind of put those up there too. So thank you, ladies, for giving that recognition to her. So on to our topic discussion stuff. I wanted to talk about ICD for just a few minutes, because there wasn't a ton of new things for ICD-10 for GI this year. But more, I want to spend more time talking about the screenings and stuff on the HCPCS side. But for ICD-10, there were 17 new GI codes this year. But 6 of them were for appendicitis. So, a lot of them were in there, and that was with the generalized and without the generalized kind of thing, how they break them up and kind of repeat them. And then they had the microbial overgrowth codes and the short bowel syndrome. So out of those new, and by the way, for all of our listeners, of course, if y'all have questions on this stuff as we're talking, y'all can start throwing out questions to us. So we'll pull them in as they come in here. Have you found, that there were specific ones out of those new groupings that, people were excited to have for GI, or that you were using right off the bat?
I think the ones that they are more excited, that I kind of have talked to other people, colleagues, that they are in GI, even though we don't really see, is that intestinal bacterial overgrowth, like that one. And then they get more specific. So it's that specificity. I love it that they come up with that specificity. So then the codes, there's not unspecified. I sometimes there's a lot of payers that don't like that unspecified, and they deny them because they need more specificity. So that the fact that they come up with this codes that giving more specificity, I really think that it's great. And then even though I don't code GI anymore, like but I review it. I constantly keep myself up to date with those new codes. And yes, I noticed that there was there were 6, like you said, 6 new appendicitis, and there were 5 for intestinal microbial overgrowth. I think there was one that I think you're probably going to talk about, the foreign body sensation of the throat. And then I think I was very happy that they finally come up with something like that, because that's a very common issue.
Yes, that whole edition of they have one for the foreign body sensation in the throat. They have one for, I think, the eye and the nose, or so and that you get so often where the patient comes in and it's just like, I feel like there's a lump and it just is there, but there isn't anything, or that's the only complaint they have, but that's justifying. Maybe they also have a family history of cancer, throat cancer, something like that, so with that and that sensation that the patient's having, now you have justification for doing some different diagnostics, things like that. But before, you were kind of looking like, how do you code that?
And this is a common complaint. It's a very common, like a lot of patients come into GI or even primary care with this common complaint, and we didn't have anything to code it with. And so I was very happy when they come up with this one. So I was like, yes, great.
Yes. Yep. Well, besides all the actual foreign body ones, did you get a load of that whole thing? With it always makes me laugh when I'm looking at those, because the foreign bodies and how now they have 100 whatever that they added for. Is it a bead? Is it a magnet? Is it a coin? Is it because kids are always sticking something somewhere in their bodies that it doesn't belong. So
actually, I was gonna say that ones that are more common is the coin, especially when I used to work in the pediatric hospital. That was like maybe if not the number one reason why a patient will come and get a EGD, because I was like, why do they always eating coins? What is going on with children? Like, yeah, infants always are like, they like to eat coins. It's incredible. But yeah, that's the number one issue I think that I was coding when I used to do GI on a pediatric.
Yep. Well, and when you think about it, where coins have been and like how many people have touched them. I mean, that just, I'm just thinking about it like bacteria wise and dirt and everything else that, you
Yes.
know, and they're sticking them in their mouths. But, you know, when you think about it, they're shiny, you know, and they make noises when you rub them together. And, you know, so yeah, it doesn't surprise me when you say that would be,
Yes.
you know, the number one thing.
I think that one along with magnets, you know, that those little magnets that some of the toys have, or like the batteries, some of the batteries, the small ones. So those were like another thing that they were always having. So I was like, oh my goodness. So that was the number one reason for an EGD to remove it, to, you know, grab it and take, you know.
Yeah, those little button batteries, right?
Yes, those button batteries, yes.
And yeah, see here. So John was on the same thought I did about the coins, the shiny,
Yeah, shiny.
And it catches their eye. They're either sticking it up their nose or trying to swallow it, right?
I know. And then sometimes their kids, they put them on their nose and then they go inside. And I was like, okay, I'm just Legos.
And
That's
so,
true.
yeah, Legos. Do we have a code? I saw that in Texas a lot. I think so. I can't remember every single one, but I wouldn't doubt that there isn't one for that, because there's plastic toys. So yes, that would fit. I don't think specifically it says Lego, but there's plastic bead, plastic jewelry, you know, and then when it goes in it, so it has all those breakdowns. So I don't think, you know, how they don't like to use the brand names and that kind of stuff, but yes, plastic toy, there definitely is.
Yeah, it might be just classified as a plastic toy or any, you know.
Yes. I was going to tell you, it just makes me think before, see, she says plastic toy will do. Yeah. So when I was a little kid, one of the hospitals by us, and this was like before HIPAA, y'all. So don't everybody start posting in there, oh my God, HIPAA. You know, this hospital that was by our house, in the emergency department, they had like a wall of shame, and they would have in there things that they had pulled out of people's like ears and noses and, you know, stuff that where they shouldn't have put it where it was. And they would like put a plaque on the wall and say what it was and who you were and where they were treated. So it was like decorative. I was just like, oh my, that, you know, nowadays, of course, we couldn't do those kind of things. But yes, they had a wall of shame for those kinds of things when I was a kid. But yeah, so moving on to the screenings, we want to talk about screening colonoscopies mainly, because we also have the other kinds. They can do screening sigmoidoscopies, yes. In the screening endoscopy section. So the link on the screen right now is for CMS, is for the site on CMS where they have that. It's a web page. So on the web page, there's got to be, I don't know, 20 different tabs for all the different screening things that Medicare pays for, like the PAP and pelvic and lung screening.
Preventative food chart, right?
Yeah, the preventive tab. So if you go here on that preventive site, where you have the link for here, the colorectal cancer screenings is one of the things that's on there. So you can look at it there. You can also find the information on it from the NDC, a National Coverage Determination that Medicare put out. It's NDC 210.3. So here's a link where you can go and pick that up and go and look for this stuff too. And there's also MedLearn, MLNCR 13017 that also kind of covers this. So you can find a whole bunch of information on it. And traditionally, you know, like for a while, it was pretty static of, you know, how the colonoscopies were for screenings. It was, you know, there wasn't a whole lot of differences in there. But this year, they made some changes in how we looked at the screenings, right?
Yeah, that is correct. There were some changes as of January 1st, 2023.
And the changes were for the minimum ages for things, right?
Mhm.
And then a different change that I wanted to make sure we pointed out was on the on positive or negative findings, right? So just in general, what does a practice need to do for a screening colonoscopy when they want to, when they want to report one? What are kind of the criteria that CMS is looking for?
Well, first, I wanted just to point out that before I talk about the screenings, I want to point out that Medicare does not cover for E&Ms prior to a screening colonoscopy because that's in the Social Security Act at Section 1861. So I wanted just to point out because some of the patients will come and they just come asymptomatic, no problems. They don't have any reason. I mean, they just want to get a pure screening. That was the purpose of the referral. So that visit, even if the provider wants to see the patient, that visit is not billable. That's number one thing. And then once the patient it goes for screening, they have to meet the criteria whether it's high risk or non-risk. And then, and if the patient is eligible, of course, I always encourage to check your portal with your MAC, whichever MAC you have or whatever jurisdiction you have to make sure you check eligibility. So you make sure that your frontline people, like your person who checks eligibility or benefits, they know and they're equipped, knowledgeable, and when it comes to checking those benefits to ensure that that patient is eligible. In Medicare portal, there's a section says screening services, and then it tells you the G code. So it says G0105 or G0104, G0121, and it will give you the next eligible date. So if that eligible date, it is a past day, let's say it was something back in 2017, the patient it won't be eligible until, if it was a colonoscopy screening, um, to be getting it like after 10 years, the patient will not be eligible until 2027. So that's a very important thing. Frequency limitations are one of the number one reason why colonoscopies get denied, because they were not, the person that it was supposed to do their due diligence on checking eligibility and benefits, they didn't kind of like did a whole evaluation, like, so they didn't check the benefits. So that's one of the, and then those are denied, you won't be able to get it paid, so that you're losing revenue in your practice. So I just want to point that one. And then going towards the codes, the G01, that's a sigmoidoscopy, and then the G0120 and the G0121, and then we have the G0105 too for non-screen, high risk. So there's criteria that they have to meet for high risk. There's a history of polyps, that's high risk. Patients that they have Crohn's disease or UC, that's high risk. So then you can able to build a G0105 if you're doing a colorectal cancer screening for high risk.
Good. Okay, and we had a question again from being in your practice. Did you find that private payors follow? Because now patients are getting screenings earlier and earlier, right? They're not waiting until they're 65 before they get their first colonoscopy. So even though the NDCs, the stuff that's out, it's out on Medicare side. Do you find that they follow the commercial payors or following Medicare, or do they all have their own policies on screenings for colonoscopies?
I think the only thing that I have seen that they might follow is the like the age guidelines, because that's come from the task force that is being implemented. So it's something that is the task force that is changing the age. So, but I don't see commercial payers implementing the G codes. I see that's more like a Medicare. And then so, however, some of them they might have similar guidelines of a CMS, and then they apply the 4,000 code series. I mean, remember, we don't have a screening colonoscopy for
Right.
a commercial payer, so we use the closest thing to it, which is the 45378. You can use that one as whether screening or diagnostic, and if it's just pure for like a diagnostic evaluation, that's the reason for the screening. There's nothing else. So I don't see payers, commercial payers, utilizing the G codes.
Okay. And they don't have that whole list of, you don't have to get into the high risk, not high risk, and all of that
No,
kind of stuff. Usually it's just like the age kind of categories
that age
with the
category.
payrolls
Yeah.
on the commercial side. Okay.
Yeah.
And a couple of people, including Jeanette here, are asking, about that E&M visit portion, how you mentioned with when they're coming in, and they're asymptomatic. It's just, hey, I want, okay. Nobody actually goes in. I don't think it says, hey, I want the
Yeah.
colonoscopy, but they will go in saying, I think it's time. I have to do this. So both Sonal, that healthy patient E&M visit before, that thing about not billing that would hold true both for Medicare and for your commercial payors when you had patients coming into the GI clinic. Yes?
Yes.
Okay. And then Jeanette, so she said, so are those marked as non-billable? So how would the practice, categorize those?
I think it depends on the practice. So you just have to create a policy for the practice about how you're going to do it. You just have to make sure that you let the physician know, they make themselves aware that that patient or that visit is not billable. Maybe you can have it as a way for reporting purposes only, just for you to keep kind of like a tracking of what has been done during the practice, and then the doctor has like a report. But those ones, if it is for Medicare patients, I used to do it as non-billable. There is some insurances that I have seen that they cover the S code. I don't remember on top of my head. I think it's S0285, if I'm not mistaken. But some of them, that is office visit. I think it's for screening, but it's not a lot of payers cover it. You will have to check with the payer to make sure that they cover, and then what are the requirements for that visit. But I think it's X0285.
Okay,
It's
yeah, a
a
lot of the
yeah.
S codes were added for Blue Cross Blue Shield
Yeah.
sometimes too. So usually if you're going to have somebody that takes it, that's where you're going to be looking.
Yeah.
But you were mentioning like the FOBT and the, so here, they reduced the minimum age to 45, but they included in there, and I just pulled this up just because I wanted to make sure I touched on the different pieces. So you've got the fecal occult blood test, the FOBT. In my office, the doctor always called that the 3-card Monty. He was like, "Yeah, make
Yes.
sure you get the
3-4.
patient." And multi-targeted stool DNA, the sDNA. That's the Cologuard, right?
Yes.
The
That's a
testing that they
Cologuard.
do now. So there's a lot of patients, I think, and that's kind of a wonderful thing, in my opinion, that they came up with, because there are a lot of patients that, I would hear all the time, there's just no way they're doing a colonoscopy, not going to happen, blah, 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 and then this Cologuard and those kind of stool DNA things started to come out. And I think that more patients, probably are getting screened than they would have, just because they were like, I am just not doing the colonoscopy. And, they hear awful things from people and stuff like that. So I was glad when that came around, that they have that as another kind of thing to kind of help out in identifying stuff. And then blood-based biomarker tests. So all
Yes.
of those they've reduced the ages for. But you wanted to also talk about the what happens if the FOBT is negative or
Okay.
positive, like how that can affect it.
Well, there was one thing that it was an expansion with this new year. Before, if a colon of FOBT, no, sorry, not a colonoscopy. If an FOBT will come back positive, and there was like, normally you get those FOBTs at your primary care, or your main family medicine doctor. So if that FOBT was a result of a stool sample based positive, then you will send the patient for a referral to a GI, and then that colonoscopy, if it lead to a colonoscopy, that colonoscopy was not a screening; it was a diagnostic because of an abnormality of a result of a test. That's not longer this year. That's not going to happen. So now they call it a complete CRC. screening, which is great because I feel like it's more benefit for the patient. And not only that, it doesn't have to include that the patient will be responsible for their deductible or the co-insurance. So it's all part of the same screening, colonoscopy, but there's some requirements. When that happens, you need to make sure that the colonoscopy, whether it's the G0105, which is not a high risk, or the G0121 for non-high risk, you need to make sure you append modifier KX in order to have that colonoscopy pay at the colonoscopy screening level. Otherwise, it will be like it will be denied, because then you're stating that it's just a colonoscopy, but that colonoscopy was a result of an abnormality of happened on the FOBT. If that makes sense.
Yeah, and what for people that are listening that might not be sure or might not know, what does modifier KX stand for?
Oh, that's a great question. So KX modifier is utilized in some instances. So to say that it's oh god, like how 1 second.
Oh.
I have it here, but sorry,
Oh, that's all right. No,
I completely
so
forgot.
it's when you're telling them that you met the requirements,
Exactly.
right?
So it is. You can use it on different type of procedures if the requirements are met. So in this case, because there's a requirement met, there was an abnormality for the FOBT. So now you're telling Medicare, this FOBT and this colonoscopy, it's together, and it's an extension. So it was expansion, and that's what it is. Thank you for saying
Sure.
that.
Yes, and that's why, and the benefit again to the patient when it can still be considered a screening and not a diagnostic under the 40,000s is no deductible, no co-insurance. So
Exactly.
they can still get their colonoscopy and not have to have that out-of-pocket stuff to themselves, while it gets investigated, right?
Correct. And then remember, like when we are dealing with Medicare, so there's a majority saying like you have to treat a abnormality, and that's what it says on the E&M, where when like why Medicare does not cover for E&M, but they do cover diagnostic, but the patient's not coming for an abnormality, they're coming for an abnormal result, which is a little different than an abnormality, like abnormal findings. That's not the same as abnormal FOBT.
Yeah, because the test is just positive. It doesn't tell you what it means. You have to
Exactly.
do the colonoscopy to see what's going on, what's causing that to be positive.
Exactly. And then I
That's my
think
thought
sometimes
process.
there's sometimes confusion here, because then, in the E&M and then for E&Ms and the Social Security access, it needs to be the colonoscopy E&M will be like it's prior, like the E&M is prior to the colonoscopy. They had to be an abnormal findings, right? Abnormal findings, but these findings are not the same one as for the abnormal FOBT. That colonoscopy is still a screening. So I don't want people to get confused, because there's already an abnormal findings of a FOBT. It's not the same one, because now that FOBT is a complete part of the complete colonoscopy.
Great, good. So yeah, so there's a lot of people. If people want to make sure they've got all this stuff on straight for this, I put all of the MLN, I put the webpage for CMS, I put the NCD, I put all that stuff in the chat so people can go and take a look at all that information. And if they have further questions on it, although you've newly moved into something else, they can look you up on LinkedIn.
Yeah.
And send you a question or connect with you to kind of see. Here's Laidy's LinkedIn profile, so you can go where she's at and follow her. You've got quite the following on LinkedIn, so and she's always very, very gracious about sharing information or answering a question if you have it. And so she'd be a great resource if you have something GI related that you are wanting to take a look at, or need an expert. Laidy would be a great person to call in to see if she could help the practice figure out maybe what was going on, or give you a little help with stuff. So I
Yes.
appreciate that, and it's good to talk about this kind of stuff. Let's see. Oh, see, look at Kim Montenegro says you need your own fan club.
I'm very fortunate. I can tell, like, I'm very fortunate that I have able to connect with so many great people, and then like I love everyone that I come to. Like, I feel like connections are important, right?
Yes, yes. And Sasha, she says you did amazing. This is a great
Mm.
subject. And I agree. I think the GI stuff is always important to kind of talk about. It's one of those specialties that is really, really necessary, but certain aspects of it, people are just like, no, I don't want to, like the screening colonoscopies. Again, no patient is like looking forward to when they hit the 10-year mark so they can go in and get
Yeah,
another one.
and then I was going to say something in addition to it. Then just keep in mind there's some codes that they have alternatives, like the enemas. They are alternatives, but they have to meet the same criteria as the colonoscopy. So they're less invasive. It's just variant enema, like a variant that they use to. It's like kind of like an X-ray, less invasive, but usually they're only utilizing it sometimes when the patient they can able to do that if the patient is nervous and doesn't want to go through the whole regimen of getting the prep. I think is everybody says that is the worst. The
Yeah.
prepping time is what is
Yeah.
killing, because once you're in the room with the provider, you're basically sedated. You don't know what's going on. So
Yep.
but the prepping time, it is the bad thing. It is really
Yeah, yeah. Once you get to the facility, you get the happy juice, and then you don't care. So
yeah, it is the prep time that is the one, the killing thing. It's like the solution is very bad. I mean, I'm still not there. I'm getting close to the age, so but oh my goodness, it
you're a
is going to
baby.
be.
You're a baby.
Mhm.
But Sorrel had Sorrel, our compliance friend, said it was very informative, and she loved the statement on the office policies. So
Yes.
putting that out there, which is always important. And Jeanette, when we're talking about connections,
Mhm.
I didn't notice that ending. Well, thank you, Jeanette. I appreciate and love just connecting with everybody. So I appreciate your time. And if you want to hang on, I'm going to bring Sonal back in now, because can you believe it? The hour's almost up already.
Are you for reals? And then
I
see, I was
am.
so nervous before
You were
coming
so
in.
nervous, and boom, we're done. So yes. So I'm going to bring Sonal back in with us. Hey, my friend.
Hey, lady, that was absolutely fantastic. So informative. We have so many
Okay, thank
friends in
you.
the GI space. So everything you said was new and we need to be aware. So thank you.
Yeah.
It was great.
Yes. And, I'm sure she'll be expanding on that stuff at the colloquium
Yeah.
on her recording. So make sure, if you're checking that out, that you don't miss it in English or in Spanish, whichever, hits you better. But Sol and we have been working on something for a little bit. Everybody knows that I have my E&M coding tools, the desk tool and the pocket tool, that are physical tools that you can use, have on your desk, have, to fit in the white coats for physicians and that everybody can use. But we wanted to create something that was kind of a little more expansive on, than just the grids and things like that. So, something that would be easier for people to kind of just put where they wanted to and use it. So Sonal and I designed some electronic E&M tools. So they are, let me pull a little thing up here. So we have e-tools for E&M. So Sonal, we have, again, I always forget the 5 categories. We have 5 E&M categories that we have tools for. And
That's
they
right.
are?
They are the office and outpatient setting. There are for consultations, inpatient and observation, our nursing facilities, as well as our emergency departments. So yeah, we're so proud that we created this really, really useful set of tools together. We collaborated for quite a while on creating it, and we included a lot of our really insightful, hopefully, tips and examples as well for each of the tools. So yeah, we're super excited. Super excited.
So yeah, as you can see kind of by the picture here, what we did was we've got the MDM table, and we also have the code for whatever category. We have all the codes with both the time and the MDM levels, but then we customize them to add in examples for some of the levels and tips and different things. So it's not just the information, it's also kind of some helpful things on putting it to good use. So they'd be good for coders, auditors, educators, for your physicians and APPs when you're kind of saying here, not just the information, but here's some ways to put it to use and some examples for you. So it gets in their heads, because most physicians and APPs, when I work with them, it's just like, show me, show me, show me, right? So that's kind of what our tips and examples on them do. So it kind of brings the highlights for the guidelines in there, plus then shows you how to put them to use. And we also came up, Sonal and I, with a promo code for the kickoff for these new tools. It's new EM 2023. So if you go to the CHCS website, you can order under the coding tools tab. The electronic tools are all out there, and you can use the promo code and get 10% off everything. And I threw in the pocket and the desk reference tools also. So if you need those or need more of those, now's a good time to kind of throw those in the cart while you're in there and get 10% off those too.
Exactly. And it's the holiday season, right? So these are really good gift items as well for everybody on your staff, right? Incredible. So if you navigate over to spcollaborative.net as well, you can find ways to purchase on there. It'll take you right to CHCS Consulting. So it's perfection. We really want you guys to start enjoying these PDF tools, because our promo code is going to expire on Black Friday at midnight. So super affordable pricing regardless, but go ahead and get that extra savings while you can. So yeah, we're super excited.
And I'm just gonna say something. I use this tool because I have it already, because I attend Betty's and previews. I use this tool for my CPMA, and they were so helpful. I'm telling you, you guys were very influencing on my CPMA. I had this one on my CPMA exam.
Oh, thank you, Lady. Yeah, and the other thing, these are immediate downloads too, so you don't have to wait for anything to get shipped to you. Once you purchase them, you could just click and download it. And we got bundles in there, so if you want one of them, if you want 3 of them, if you want, and we also made a definitions one. So if you purchase any of the tools, not only do you get the 10% off with the code, then you also get a free definitions download. So that's something else that we kind of threw in there, just to kind of sweeten the pot, because we're so nice, right?
That's right.
You guys are. Yeah.
So I just want to say thanks to everybody. Now, normally the 2 Thursdays from now will be Thanksgiving. So of course, I don't think anybody's going to want to sit on Thanksgiving when all their family's around and they're getting, stuffed on turkey and whatever, to come on and sit and play with us for an hour. So my guest next time is going to be Amy Anderson, and I'm so thrilled to have her. She and I worked together before at a consulting firm, and she has her own consulting firm with her partner Cheyenne Brinson, who also used to work at the same consulting firm. So they have Cheyenne Brinson, Brinson Anderson consulting company, and they do plastics and a lot of other different things, but she has some videos that she puts on LinkedIn all the time. So she's a beautiful young lady. So she's going to come on and we're going to talk about plastics and things like that. So that'll be a good program. So that'll be the week after Thanksgiving. So I'll end up doing 2 in a row after that to kind of catch back up from having Thanksgiving off. So make sure you're watching for that notice. Go to the site, take a look at all the nice little tools we made. Lady, again, thank you so much for coming on today. I really appreciate it. It was fun talking to you. And
Thank you.
Sonal, my friend, thank you for coming on to do the little kickoff
Thank
thing
you.
and talk about the colloquium at the beginning.
Right.
And everybody, y'all have a happy Thanksgiving, right? Since
Yes.
Yes, happy
Betty,
Thanksgiving, everybody.
yes,
Yes.
yes. Can I just say one more thing before
Yes.
we just? Okay, I just wanted to give up. For people that they are inspiring to become a GI or anything in general, like any in the healthcare, my advice is to pursue relevant education. Make sure you always willing to kind of put yourself out there, keep yourself up to date. Reading is a key for this field. That's the biggest thing that you want to be successful in this industry. You need to love to read. Networking is essential. Connecting with those people that they are there, that they're already on the field to, like I connected with you, both of you, or a lot more, and then you guys have helped me so much to grow. And then so that's what I'm always saying. Connections are important, and then be respectful, but also be respectful with other people's time. Because they're busy, and then but you also have to be willing to pay it forward when the time comes. So I'm just wanted to put it out there for the world.
You always have like the best little things to say, lady. I tell
Oh
you.
no,
So sweet.
You.
I
Was
really
it
love
Sonal?
networking, and then but I think it's important
Yes.
for people to be respectful of the time, because in this world we're all busy, but it doesn't mean that sometimes we don't want to have answer. It's just that we are doing so many things that it is that happens to me. So if someone send me a message, I will respond, but it will take me time, but I will respond.
Yes. Sonal, any parting words for you, my friend?
No, this was an amazing, incredible, necessary session. So thank you
Thank
both
you.
for providing tummy talk, because I think it was, like I said, it's 2024 is coming up and these new changes. So thank you so much. This is amazing. And I look forward to seeing you both all weekend long with the colloquium.
Yes.
So
Yes.
excited.
Me too.
All right.
Great.
Thanks, y'all.
Thank
We'll see
you.
you
Thanks,
soon.
everybody.
Bye.
Bye.